meeting to order. Welcome to meeting number 30 of the House of Commons Standing Committee on Health. Today we're going to meet for 2 hours with witnesses on our study of children's health. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23, 2022. I'd like to make a few comments for the benefit of witnesses and members. Please wait until I recognize you before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. Interpretation for those on Zoom, you have the choice at the bottom of your screen of either floor, English, or French. For those of you in the room, you can use the earpiece and select the desired channel. Screenshots or taking photos of your screen is not permitted. The proceedings will be made available via the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. Je veux accueillir un nouveau député ici, M. Perron. Bienvenue au comité. And I see Ms. Vienne is I suppose, filling in, but welcome. It's nice to have you here. I now would like to welcome our witnesses who are with us this afternoon, and it's an absolute pleasure after so long to see witnesses physically present. So a warm welcome. Appearing as individuals, we have Dr. Michael Ungar, Canada Research Chair in Child, Family and Community Resilience Research Centre at Dalhousie University, my alma mater. The Canadian Cancer Society, represented by Kelly Mazzotti, Vice President, Advocacy, and Helen Sonia, Director, Advocacy. From the Canadian Dental Association, Dr. Lynn Tompkins, President, and Dr. Aaron Burry, Chief Executive Officer. And from the Pharma Science, Sarah Douglas, Senior Manager, Government Affairs. And from Speech, Language, and Audiology Canada, Don Wilson, Chief Executive Officer, and Carrie, Director, Speech Language Pathology and Communication Health Assistance. Thank you all for taking the time to appear today. As I believe you were informed, each organization has up to 5 minutes for an opening statement. I'm going to invite Dr. Ungar to begin. Dr. Ungar, welcome to the committee. You now have the floor.
A huge thank you, Mr. Chair, for this opportunity. What I'd like to do is just sort of bring you a little bit into my world, which is that to study resilience of children. I know that we're going to be experiencing a huge amount of delayed pathology because of COVID, but I also want to sort of bring you that message that there's a lot of resources potentially in our communities. So when I think about the work I do, I'm also thinking about a young fellow, 11 years old, who in an elementary school has himself a great deal of stigma that he's exposed to. He lives in poverty, social housing. His parents have incredibly very few resources to cope with him. And yet this fellow who has very bad teeth, is very teased in his community, finds inside his school community a custodian, a janitor of the school, that actually takes him under his wing and provides an element of protection and a sense of belonging. Now, we don't normally think of custodians at our children's schools as part of a mental health strategy. But what my research on resilience globally is actually showing us is that we need to begin to think about more resilience and the health of our children in a more multi-systemic way. We need really to get beyond these simplistic solutions like offer a child a self-esteem workshop or a mindfulness-based stress reduction workshop, or offer them simply a better educational experience. What the research is actually emerging is, and what I so appreciate by a panel like today, where you're seeing many aspects of a child's life represented, is that we understand that when children's lives are thought about in their complexity, we tend to get better social policies. So that means how the courts sentence children, or indeed how schools respond to children. So indeed, what my work is really looking at this cascade of positive effects. If we can jumpstart one system, whether it's an educational system or better support for families, the real trick with policy that seems to have an impact on long-term resilience for children is when we understand those those almost like dominoes hitting one another to create the kinds of changes that we're actually looking for. So again, in terms of my research and my work, I'm actually now involved in looking at the impact of boom and bust economies on children and families in those communities that, as we green our economy, that we're actually going to be displacing literally hundreds and hundreds of families and indeed communities who are dependent on the oil and gas industries in places like Alberta, indeed here on the East Coast, St. John, and indeed in Newfoundland as well. So when we begin to think about resilience, when we think about children's well-being and mental health, which is my concern, I'm going to have to sort of think about the impact even of macroeconomic factors as they change family patterns and recreational services and opportunities for children to do the kinds of things that they need to do. And again, if I might introduce a concept for policymakers, it's this idea of the differential impact. What you offer as a policy might have a different impact on a child depending on three things. First, what is their actual risks that they experience? Second, what is the protective factors which are most likely to impact that risk and be helpful? And of course, what is the outcome that you're trying to achieve? So just sort of wrapping this up, if I could, all of that leads me to think about, a school outside of Saskatoon, St. Mary's, that when they renovated the school, they were having trouble, even though they serve a large population of Indigenous children and refugee children and children who are visible minorities. They were having trouble getting those children to the local children's hospital for the appointments that they needed. And so what the school board did was, when they renovated St. Mary's School, a K-9 school, they actually brought and built a purpose-built pediatrics clinic in the school, so that then access to those services where it was easier for families to get right close to their homes. That is the kind of multi-systemic thinking, these kind of reaching beyond single simplistic solutions to very complex problems, where systems are working together, that is likely to create this cascade of positive impacts, which is actually going to make our children more resilient, especially as we come out of this period of COVID, where there have been so many delays in terms of their psychological and social development. And I'll leave it at that.
Thank you very much, Dr. Ungar. Next, we're going to hear from the Canadian Dental Association. Dr. Tompkins, I believe. You have the floor for the next 5 minutes. Welcome.
Thank you, Mr. Chair. Bon matin à tous les membres du comité.
Good morning to all members of the committee.
I would like to take a moment to recognize that I am joining you here today on the unceded territory of the Algonquin Anishinaabe people. I'd also like to thank you for taking the time to study this important topic of children's health. And I sincerely appreciate your inviting the Canadian Dental Association to participate in this morning's meeting. At the Canadian Dental Association, we know that oral health is an essential component of overall health, and we believe that Canadians have a right to good oral health. That is why we fully support efforts by all levels of government to improve Canadians' oral health and enhance their access to dental care. Poor oral health strains other parts of the healthcare system, whether through hospital visits for emergencies or managing the long-term impacts of poor oral health on systemic disease. This is particularly the case with children, as good oral health in childhood serves as a foundation for the rest of a person's life. Unfortunately, in spite of significant progress over past decades, tooth decay remains the most common, yet preventable, chronic childhood disease in Canada. It is the most common reason for Canadian children to undergo day surgery, and it is the leading cause of children missing school. Beyond the risk of pain and infection, tooth decay, particularly in young children, can impact eating, sleep and proper growth, speech, tooth loss and malocclusion, and increases the need for dental treatment later in life. And on a personal level, I can tell you, having been in practice for over 35 years, it is heart-wrenching to see a young child with severe dental decay. This often requires treatment under general anesthesia in a surgical facility, which can also involve lengthy wait times. In addition to the impact on a child's health, the experience can lead to long-term dental fear and anxiety. Therefore, it is so important to ensure that Canadian parents can access dental care for their children within months of the eruption of the first tooth. Early exposure to good oral hygiene habits and preventive care can make a lifetime of difference for a person's mouth. And while Canada compares favorably to many other countries, too many people, including children, still do not receive the dental care they need. More than 6 million Canadians each year avoid visiting the dentist, primarily because of cost. This is especially true for low-income families. While every province and territory in this country has publicly funded dental programs for children, these vary from jurisdiction to jurisdiction, leaving significant gaps. This is why the CDA welcomed the federal government's commitment earlier this year to a multi-billion-dollar ongoing investment in enhancing access to dental care for Canadians. It comes after years of encouraging federal investments in dental care by the CDA. And all those who have advocated on this issue, whether on behalf of CDA, provincial and territorial dental associations, or other health organizations, should be proud that their hard work has led to this once-in-a-generation opportunity. In particular, CDA appreciates the phased approach being taken by the federal government, illustrated by last week's announcement of a proposed Canada Dental Benefit, and this week's introduction of legislation to implement that proposal. This will allow time to consult and collaborate with all relevant stakeholders on a long-term solution that is well-informed, targeted, comprehensive, and effective. We appreciate that this interim measure balances supporting the oral health needs of Canadians with several key priorities for Canada's dentists. We have also appreciated the close collaboration demonstrated so far by Minister Duclos and his team at Health Canada, and we look forward to working with him in the months ahead. And we would also like to thank Mr. Don Davies for his advocacy on oral health over the past number of years, which has culminated in this historic federal investment in enhancing dental care for Canadians. Finally, beyond reducing financial barriers to accessing dental care, there are several other items that CDA has focused on in its written brief to the committee. These include recommendations that the federal government implement the remaining measures of Canada's healthy eating strategy with a focus on food and beverage marketing to children under age 13, to review its programs providing funding for drinking water systems and look for ways to support enhanced access to community water fluoridation, and to examine the administration of the NHB program for First Nations and Inuit to ensure timely access to surgical facilities for children requiring dental treatment under general anesthesia. And as well, we believe it is essential for the federal government to include oral health as a component in any studies on the long-term impact of the COVID-19 pandemic on children. Thank you once again for the opportunity to participate in today's meeting, and I would be happy, along with CDA CEO, Dr. Aaron Burry, to answer any questions that you might have. Thank you.
Thank you very much, Dr. Tompkins. Next, from Pharma Science, Sarah Douglas. Ms.
Thank
Douglas,
you. Good morning.
You have the floor.
Good morning, Mr. Chair and members of the committee. Thank you for inviting Pharma Science to appear before the House of Commons Standing Committee on Health. I'm here today to share our perspective as a manufacturer of medicines on the crucial issue of access to pediatric drug formulations and the challenges we face in bringing these child-friendly formulations to market in Canada. For some context about who we are, Pharma Science is the second largest Canadian-owned pharmaceutical company. Founded nearly 40 years ago by pharmacists Morris Goodman and Ted Wise, we're a proudly Canadian company with our global headquarters, manufacturing facilities, and R&D labs all located across the Greater Montreal area, where we employ almost 1,500 people. Importantly, we invest about $40 to $50 million annually in R&D in Canada, consistently appearing amongst the top 100 companies investing in R&D. En 2019, Pharma Science a comparu devant.
In 2019, Pharma Science appeared before the House Industry Committee to share our concerns in this matter. When compared to other similar countries, Canada lags behind when it comes to the availability of specific drug preparations for pediatric populations. This is not for want of demand. Pediatricians, nurses, pharmacists, and the parents of sick children have always been asking for specific pediatric formulations. Pediatric formulations are drugs which are in a dosing regimen which is adapted to children, with some characteristics that are different from the adult products. There could be specific formulation ingredient differences, or the form of dose versus liquid versus solid, the concentration of active ingredients, product indications for the approved project, and packaging.
Necessarily simple to develop, but essential to have. Nonetheless, there are numerous new approaches that allow us to tackle the challenges, but it is market conditions that have made it difficult for manufacturers to launch these formulations in a commercially viable manner. That being said, I do want to recognize that there has been progress since 2019, including Health Canada's Pediatric Drug Action Plan in development and a recent decision from the Pan-Canadian Pharmaceutical Alliance that will allow Pharmascience to market levetiracetam, one of the most needed pediatric formulations for epileptic children. This decision marks a possible breakthrough in the reimbursement of pediatric drugs, but it's still early and there's much more work to do. As a manufacturer, I'd like to highlight our main general concerns that make it difficult to manufacture pediatric formulations in Canada. First, the pediatric market is completely different than the adult one. It is much smaller. The market size difference alone challenges the viability to market these formulations. On top of this, pediatric drugs have been treated the same way as their adult equivalents in pricing. Given the extra effort it takes to market pediatric formulations, this makes prices so low that no one can successfully market the drug. A different pricing grid for public reimbursement of pediatric drugs is needed. Third, nearly all of the drugs identified by pediatricians needing a pediatric formulation are off patent. This makes the R&D investments by manufacturers extremely risky for pediatric formulations, as we may not be able to recoup the investment. Heureusement, Santé Canada a entendu l'appel et élabore un plan d'action pédiatrique sur...
Happily, Health Canada has heard the call and has drafted a pediatric action plan for drugs. The idea is to improve availability of pediatric formulations in Canada. We've been working closely with Health Canada to develop this plan. And when it comes to the Pediatric Drug Action Plan, the steps which would help us to put more pediatric formulations onto the market include exemption from submission costs and exclusive periods for the pediatric formulations that are off patent or generic, measures which already exist in the European Union and the United States. These regions recognize the need to encourage the creation and availability of these drugs.
Absolutely crucial for Health Canada to implement regulatory changes to support the development of new pediatric formulations. And this isn't just a call from us. Many other stakeholders in the pediatric space put out a call for change earlier this year. It will also be critical to change the public reimbursement environment and to recognize that pediatric drug prices need a different pricing standard than adult dosage forms. We need to keep up the momentum to get this done, and these steps that are made today will create a better future for children. Pharmascience is one of the few Canadian manufacturers that have taken the risk to invest in pediatric drug formulations to meet this important unmet need in spite of these unfavorable market conditions. At stake is the health and safety of children. If the policy changes that we are endeavoring are implemented, simple, affordable, and significant innovation can be brought to the practice of pediatrics. Once again, thank you for the invitation to appear, and I'd be pleased to answer any questions that you may have.
Thank you very much, Ms. Douglas. Next from Speech, Language and Audiology Canada, I believe Don Wilson, you're going to be speaking for the group. You have the floor for the next 5 minutes. Welcome to the committee.
Thank you, Mr. Chair, and members of the Health Committee. I would like to thank you on behalf of Speech, Language, Audiology Canada and our 7,500 members. And I appreciate the opportunity to speak to you today about timely diagnosis and access to speech language pathology and audiology services for children. We know that effective communication is foundational to a child's social, emotional, and educational development. Research has shown that the first 3 years is a critical period for normal speech, language, and hearing development. Early identification of difficulties is therefore key to ensuring timely access to appropriate interventions for long-term success. Learning is cumulative. Difficulties not addressed earlier compounded in later years, and thus addressing communication health needs early has a decisive influence on later academic accomplishments, health, well-being, and quality of life. Our members are vital in terms of being part of a primary healthcare team to support this process. Across Canada, our services are offered through a combination of public, private, and school-based providers. However, insufficient positions and inconsistencies in service delivery result in inadequate access to care. The situation is worse in many rural and remote areas. Parents report lengthy wait lists in both public and private settings during this critical developmental window, which can be exacerbated for specialized groups such as children with autism. The demand for our services exceeds the capacity of available professionals. Detection of hearing health issues is critical in the very early stages of life. Access across Canada is inconsistent. Almost half of the provinces and territories received a failing grade on a 2019 Early Hearing Detection and Intervention Report Card. Relatedly, most provinces and territories do not offer universal newborn screening for congenital cytomegalovirus, despite it being the most common infection transmitted from mother to baby during pregnancy. The prevalence rate of CCMV is approximately 1 in 200 newborns and is the leading non-genetic cause of neurologic disabilities and permanent hearing loss worldwide. In the preschool population, acute otitis media or middle ear infections are extremely common, affecting approximately 75% of children at least once before starting school. Chronic suppurative otitis media in early childhood can lead to increased risk of auditory processing disorders later in life. When speaking to their child's healthcare providers, parents often report speech and language delays as a primary concern, and prevalence data suggests these difficulties are common. Speech sound disorders in preschool children range from 2 to 19%. Developmental language disorder is one of the most common childhood disorders, affecting 7% of children, and speech sound disorders range from 2.3 to 24%. Communication difficulties follow a child later into their school years, and a recent report indicated that there are insufficient speech-language pathologists working in Canadian schools to meet the needs of students who require their services. These staffing shortages are long-standing. However, closure of daycare and schools during COVID-19 further exacerbated the issue with increased levels of burnout and heavier caseloads. Prior to the pandemic, many Indigenous children were already missing literacy benchmarks for their age groups. Long-standing communication difficulties and their far-reaching effects cannot be easily remediated, though an early investment can have a multiplier effect. A dollar invested in addressing problems today will mean many more saved in the long term. In other words, inaction now carries very high long-term costs. Delayed intervention costs 10 times more than if intervention was accessed early. Children who do not achieve optimal early language learning are not prepared nor equipped for compulsory formal education by age 5. We recommend that the federal government work with provinces and territories through recent daycare deals to train early childhood educators on speech and hearing delays, that we integrate speech-language pathology and audiology services into licensed daycare settings in collaboration with provinces and territories, that the federal government establish a primary healthcare transition fund to assist provinces and territories in their work to expand access to speech-language pathologists and audiologists through primary healthcare teams. And of course, we desperately need initiatives to recruit and retain speech-language pathologists and audiologists in any federal efforts to improve health human resources. Again, thank you for the opportunity to be here today, and we are happy to answer questions.
Thank you very much, Ms. Wilson. Next, we're going to hear from the Canadian Cancer Society. Ms. Mazzotti, I know you had some trouble getting online, but I see you there now, and I know that you're no stranger to parliamentary committees, so you know the drill. You have the floor for the next 5 minutes. Thanks for your patience, and welcome.
Thank you, Chair, and thank you for your patience. I do also really appreciate the support from House of Commons staff and IT staff. Now, I can hear an echo. Can you? All good? Okay. Good morning. Thank you, Chair and committee members, for having me here today. My name is Kelly Masadi. I'm Vice President of Advocacy, and here with me today is Helena Sonia, Director of Advocacy. Before I begin my remarks, I'd like to first acknowledge that we are both speaking to you today from the traditional unceded territory of the Anishinaabe Algonquin people. I'm pleased on behalf of the Canadian Cancer Society to participate in today's committee discussion regarding children's health. Cancer is the leading cause of disease-related death in children under the age of 15 years. This is why the Canadian Cancer Society has invested $16.4 million in childhood cancer research projects across the country in the past 5 years alone. In trusted partnership with donors and volunteers, we work relentlessly to improve the lives of those affected by cancer through world-class research, transformative advocacy, and compassionate support. We also work to provide real-time support to people with cancer and caregivers. Just last year alone, we provided trusted information to over 125,000 users of cancer.ca looking for information specific to childhood cancer. It's auspicious that we're gathered here today to discuss this topic, given that September is both nationally and internationally recognized as Childhood Cancer Awareness Month. We know that an estimated 1,100 children under the age of 14 were expected to have faced a cancer diagnosis in 2021. However, it's suspected that diagnosis for many cancers has fallen since the onset of COVID-19 pandemic in Canada. We've had success diagnosing and treating cancer impacting children over the past number of decades, thanks to world-class research and innovative treatments. The 5-year survival rate for childhood cancer is about 84%. This means about 84% of children with cancer survive at least 5 years past their diagnosis. Although childhood cancers account for less than 1% of all cancer cases diagnosed in Canada, they have a significant and lasting impact on both the individuals and their caregivers. An estimated 2/3 of childhood cancer survivors have at least one chronic or late side effect from their cancer therapy, including a high risk of physical and mental health problems or secondary cancers. I'll now turn my remarks over to Helena.
Good morning. I will use our remaining time to highlight several areas that require further investigation and resolution to support children's health. It's important to note that the causes of most childhood cancers are largely unknown, and modifiable risk factors usually have little to no effect on most childhood cancers. But it is important to recognize that teaching healthy lifestyle choices and preventing certain environmental exposures in childhood may reduce cancer risk much later in life. Each of these recommendations we would be pleased to discuss further during our question and answer period, or provide further information in writing should committee members wish. Firstly, the overwhelming majority of people who smoke begin as underage youth. Far more needs to be done to reduce youth tobacco use to help achieve the goal of under 5% prevalence of tobacco use by 2035. Canada is currently faced with a dramatic increase in youth vaping, leading to overall increases in youth nicotine addiction. Among high school students in Canada, in grades 10 to 12, youth vaping increased from 9% in the 2014-2015 school year to 16% in 2016-2017 to 29% in 2018-2019, tripling over a 4-year period. It is essential that the government take further action to reduce youth vaping, in particular to finalize regulations restricting flavors on e-cigarettes. Research shows that as much as 90% of food and beverages marketed to children for processed foods are high in sugar, salt, and/or saturated fats. Food and beverage marketing has an impact on the foods that children eat, from their food preferences and beliefs, the foods they beg their caregivers to buy, rising rates of childhood obesity, and increased risk factors for chronic diseases such as diabetes, heart disease, stroke, and cancer. There's a clear need for the government to fulfill their commitment to restrict the commercial marketing of all food and beverages to children and youth. Everyone in Canada needs better palliative care options, regardless of age, gender, income, race, or sexuality. Significant work is required to give families who need palliative care, particularly for a child, the support they deserve, including improving education and training for healthcare workers, addressing equity, supporting children struggling with grief, establishing standards, and improving the quality of care through better research and data collection. There's considerable space for the federal government to lead here, in addition to the necessary improvements to care delivery by the provinces and territories. Canadians, and especially our children, should also have equitable access to life-saving drugs that play an essential role in treatment and can greatly improve health outcomes and quality of life for people living with cancer. As the government provides further detail on their pharmacare commitment, we would encourage the government to improve access to drugs, accommodate and accelerate approval and funding for innovative cancer treatments and clinical trials, and remove unnecessary administrative barriers to ensure children with cancer have equitable access to the cancer drugs they require without financial hardship on their caregivers, regardless of where they live and where the drugs are taken. Finally, we know federal, provincial, and territorial governments are due to discuss the state of health funding transfers. From our perspective, ensuring governments are properly funded to address the critical issues facing Canadians is paramount. While governments may debate the funding amount needed and the funding conditions, what we want to see is taxpayer dollars focused on improving health outcomes, measuring those outcomes, and supporting vital inputs like health research that give children a better chance to live and have a healthier and higher quality of life. Because of investments in world-leading research and clinical trials, we now have a better understanding of childhood disease and treatments that are helping children live longer. We will continue to invest our focus and our dollars to support this work and encourage the government to do so as well. I want to thank the committee again for having us here today. We look forward to your questions. Thank you.
Thanks to you both. We're now going to proceed directly to questions, beginning with Mr. Barrett for 6 minutes.
Thanks very much, Chair. Thanks to all the witnesses for joining us in person and virtually today. It's great that we're all gathered to talk about children's health. My question through you, Chair, is to our witnesses from the Canadian Cancer Society. It deals specifically with an issue that's been flagged for us as a result of restrictions and measures that were put in place because of COVID-19 that have caused delays in the care and screening appointments for cancers. And what I'm looking to find out is if the backlog of care and screening appointments for children is at the same rate, less than, or worse than it is for adults.
Thank you very much for the question, and it's nice to see you. We absolutely know that there is an overall delay in Canadians anywhere living in the country accessing, whether it's access to diagnostics, the treatments, and the surgeries. Unfortunately, the information is not available at this time, but we can certainly have an additional poke around for you following this committee appearance today to ascertain whether or not the delay is more significant for the childhood population. I think that we certainly know that generally speaking, that there is a delay to all different types of cancer diagnosis throughout all age groups. So we will get back to you with a specific number, but I would certainly say that my hunch is that it is applicable to this age group as well.
Well, thanks very much, and I look forward to that information that you're able to track down. What does, in practical terms, what can you share with us what the effect is of those delayed diagnostics, care, and screening for children who would have had a cancer diagnosis potentially earlier, but it ends up being missed or significantly delayed? What's the impact on them and their families and on the ability for them to be treated?
That's a fantastic question. And I think that since the start of the pandemic, the Canadian Cancer Society has done our very best to conduct patient and caregiver surveys and share these results with government to really demonstrate just the increased levels of anxiety and stress that we see with people living with cancer, especially those little ones. And just, for example, at the start of the pandemic, and I would say that the shift has happened over the past couple of years, caregivers were not able to attend appointments with their children. And so that would absolutely cause an increased levels of anxiety and stress for all different family members. Something that I would also add is around grief and bereavement, not necessarily having the access to those types of supports in a comprehensive manner, just because the system was rather inundated with additional mental health requests at those times. We also know that through the psychosocial impacts and requests that come from the cancer community has always been a concern. For example, the Canadian Partnership Against Cancer released a report a couple of years ago that really spoke, like one of the top recommendations that came from this report was the need for long-term psychosocial support for the cancer community. And so, you know, as Kelly mentioned, as part of our witness testimony, the Canadian Cancer Society is proud to provide information and support services to people living with cancer and their loved ones in over 200 different types of languages. Kelly, is there anything that you wanted to add?
Thanks, Helena. That was great. Yes, just 2 points as it relates to later stage diagnoses. If we miss that, then there is those types that can be harder to treat, as well as cost the system more. Thanks, Helena.
Okay, thank you very much. So I have a series of additional questions. I'm probably not going to get through them all. What would you say, and perhaps this is something that you could later furnish the committee with additional information if you have it. What are the immediate steps that could be taken to rectify these backlogs, specifically as it deals with children? Would it be addressing the number of pediatric oncologists? Would it be other specialties, hematology? Is it equipment? Better research? So where is the most acute pain point right now, and how do you think that we can address that?
It's a great question that I think requires a multi-pronged response. So we were thrilled to see in the most recent budget this commitment to $2 billion to help unclog the backlogs. I would say that type of investment and then the continued discussions that are ongoing between provinces and territories and the federal government need to prioritize cancer. We know that approximately 2 in 5 Canadians will be diagnosed with cancer, and this absolutely applies across all different age groups. I do think that, I apologize, you're actually going to enjoy this fact, but I am 9 months pregnant, and so pregnancy brain is a real factor.
Congratulations. Yeah, that's incredible.
So I have an extra reason to provide you with strong testimony today. But I think that we know that healthcare providers, both at the front line of service delivery and in supportive roles, play a key role in providing accessible quality cancer care to Canadians. And so the Canadian Cancer Society supports recommendations from other healthcare provider stakeholders to implement a comprehensive and integrated pan-Canadian health human resources strategy, as well as continued investments in health research. And as I mentioned before as well in my testimony around just that increased access to palliative care, as well as those life-saving treatments.
Thank you, Ms. Sinny.
And if I can, Mr. Chair, I'd just like to say thanks very much for joining us at 9 months. Wish you very good health to you, your child, and your family. Thanks so much.
Very kind. Thank you.
Thank you, Mr. Barrett. Next, Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, to joining us with us today. And I also want to recognize it's a Cancer Awareness Month today. So my first question is going to be the Cancer Society. Cancer is one of the leading cause of disease-related deaths in Canadian children over the age of 1 month. And also, almost 84% of Canadians survive a cancer diagnosis after 5 years. And this survival rate can be improved with the new and better treatment. So last year, government launched the biomanufacture and life sciences strategy with a commitment of $2.2 billion over 7 years. I'm wondering if the Canadian Cancer Society can comment on how innovation in healthcare can improve patient outcome.
I can start with that. We want cancer patients to have access to the best treatment in the location of their choice. And so any additional funding from the federal government to support innovation, to support drugs and technology that will eventually help cancer patients in the location of their choice is something that the Canadian Cancer Society is supportive of and thanks the government for. Helen, I don't know if you want to add anything.
Not at this time. Thank you for the question.
So next question is to the Dental Association. And I know we have a broad topic today, primary care, which includes acute and chronic disease. I know, Dr. Tompkins, we had a meeting in my office in Brampton, and thank you the work you are doing for all kids, the dental thing. And government is proposing a new Canada dental benefit for eligible families. Do you see unique barriers for children seeking to access dental care for rural and remote communities for a diverse population? What should be done to improve equitable access so everyone can get the access to dental care?
Well, thank you for that question, because cost alone is not a barrier. Is not the only barrier for Canadians to access dental care and children, and we do appreciate this new program that's coming out. That is a good start, we feel, and look forward to continuing to work with the minister as we see things roll out. Certainly in remote and rural communities, there are challenges in terms of access, and particularly with Indigenous children who live sometimes great distances from any centers that provide care. So we support all efforts to encourage dentists and dental staff to locate into remote and rural communities, as well as looking at building or creating surgical centers that are close to sites where the communities can access them, especially Indigenous-led surgical sites, so that children there don't have to be transported from Sachs Harbor down to Edmonton or Calgary to have their dentistry done. So we do appreciate any efforts. That could include things like loan forgiveness for dental graduates coming out who are heavily indebted when they graduate from dental school, to encourage them to go to these areas.
We also heard that unhealthy diet and negative health effects are not always evenly distributed across different populations in Canada. And the Cancer Society also talking about the healthy diet and high in saturated fat. So we know the front label packaging. We are already working on that. How we can federal government can be more impactful, so the children can get the healthy diet and they can adopt that lifestyle. Any witnesses, if they want to comment, please comment on that.
If I may, thank you.
I'm happy to jump in here to start. Thank you for the question. Oh, go ahead. I'm sorry about that.
Well, we're on the same page. I think we would like to see the healthy eating strategy complete the recommendations there. In terms of dentistry, part of getting children to the dentist early, and the Canadian Dental Association does advocate and recommend that children be brought to the dentist within 6 months of the eruption of the first tooth. That gives the dentist the opportunity to assess the child's risk of caries and dental cavities, and also to talk to the parents about healthy eating, healthy diet, brushing and flossing, and so on. So I think early intervention, early meeting with the child and the families, because it is a family issue, would go a long way to get the child started on the right path. So thank you.
And Cancer Society want to comment, please?
Yes, thanks for that question. We are entirely supportive of the front of package labeling and thank the government for implementing this and moving it along. We would also echo the comments of the previous witness to encourage the government to implement all factors of the healthy living strategy. We are Canadian Cancer Society as part of the Marketing to Kids Coalition. And as part of that coalition and on our own, we wholeheartedly support the introduction of the ban of marketing to kids in any form. We're supportive of the new bill that's been introduced, Bill C-252. But this is on Health Canada's forward regulatory plan, and this bill is proceeding through the House and should not delay launching the CG1 on marketing to kids in the fall of 23.
Okay, thank you, Ms. Sidhu and Ms. Mazzotti. Suite, c'est le tour de Monsieur Perron pour la...
And now it's over to Mr. Perron for the next 6 minutes. Thank you, Chair, and thank you to all of our witnesses. And I'd like to also welcome the people that I haven't had a chance to greet earlier. Beginning with Ms. Wilson, you talked about the importance of daycare services. Oh, just a moment. I'll wait for you to put on your headsets. All right. In your statement, you referred to daycares and the importance of having speech-language services or audiology early in order to be able to screen. You also mentioned that the transition fund would be necessary so that provinces and territories could, in fact, do their work. Could you elaborate, please?
Thank you very much for the question. I think what's really important is that there be awareness building about the need for early intervention. We know that the early intervention of speech and language problems is essential to child development services, and without that early intervention, the speech and language problems are further delayed.
Apologies for interrupting you, but in order to make sure this happens, would you say that it would be urgent for the federal government to increase transfer payments to the provinces to ensure that the services you talked about, daycare and education, to be sure that the health services are also provided with local decision-making powers?
And we applaud the federal government for their investment in the daycare deals. And yes, we absolutely believe that the deployment of those daycare deals is imperative because we can work directly in daycare settings with early childhood educators to train them on screening.
Thank you very much. I'm sorry, but we have a very limited time. So I would also congratulate the government for investing and respecting Quebec's competency and jurisdiction. And now, Mr. Unger, Dr. Unger. You specified in your introduction the interrelationship of various factors, and you talked about the domino effect, education, family, social impacts. Do you believe that health needs are equal across the territory, or are there regional differences that it's important to consider? Briefly, please.
Very definitely, that there are specific, in fact, that's what we look at when we look at patterns of coping or resilience to populations. We look at very specific cultural and contextual needs due to geography, language, cultural heritage, and of course, histories of trauma, whether that's refugees coming into the country or otherwise. But this is always a question of, in a sense, getting out of this pattern of thinking that we can solve individually focused problems. A simple example of that is polio is going up, not because we don't have vaccines, but because we don't have sociologists addressing the problems. In other words, we need to get out of this idea that, for instance, the way our Social Sciences and Humanities Research Council, which funds humanities and social science research, is separated from our Canadian Institutes of Health Research, which funds all the health research. We, if anything, have learned that we need to be thinking more about individual populations and their particular needs in more systemic ways.
Donc, vous venez de dire qu'il faut se concentrer.
So you said that we should be focused on individuals, populations, and their own specific needs. I'm sorry to have to interrupt you, but I see that my time is running out quickly. So it's important, yes or no, it's important that the decision-making power be decentralized to provide services which are adapted to the communities. Is that correct?
Merci. Merci infiniment.
Thank you very much.
Madame Tompkins.
And now, Ms. Tompkins, you talked about the fact that it's important to have money used for dental health, that there be public funding. Now, I'm sure you're aware of the issues of jurisdiction that we have, whereas health is a provincial matter, the federal government has the money, and the provinces are unanimous, by the way, not just Quebec, but all the 10 provinces are asking for an increase in health transfer payments of 35% so that the money could be there for health. So do you support that request? And second question, are you concerned, because the current system, the way I understand it, the way I understand C31 is that you could have a dental bill and you could receive $150 if a parent presents a teeth cleaning bill for $100. The $550 that remain, there would be no control to find out whether it's being used for dental health. Is that a concern for you? Quickly, please, for both questions.
So in terms of the funding and the access to dental care, we do look to see a much more dialogue going on between the provinces and the federal government. In terms of how the money is going to be used, I think Mr. Boissonneau said it's going to be on the honor system, and we hope that Canadians are going to use the money so that children can get in to see the dentist for their care. So this is one reason why we're pleased that it's coming. This is being rolled out in stages so that there is the opportunity for intergovernmental dialogue, and so that the patients who are seeking to receive the care are not caught in the middle. So this is going to be an ongoing discussion between the federal and the provincial governments. And as I've said before, I'll talk about dentistry, but I'll leave politics to the politicians.
Merci beaucoup. Donc, c'est important de décentraliser les décisions.
Thank you very much. So you're saying it's important to decentralize decisions?
I say it's important to continue the dialogue so that we reach the ultimate goal of making sure kids get to the dentist.
Merci. Mr. Davies, please.
Thank you, Mr. Chair, and thank you to all the witnesses for being here. Ms. Wilson, I'd like to begin with you. You've painted, I think, an extremely clear picture of the extensive needs of children and the critical importance of early intervention in terms of speech and communications development for kids, particularly under the age of, I think, 3. Can you give us a sense of the scope of the lack of access to effective therapy? Like, is this a small problem? Is this a medium problem? Or is this a problem across the country in terms of the lack of access of kids getting the access to therapy they need?
Yes, I can definitely speak to that. I think the scope of this is nationwide. This is something that is in all elements of our society, in schools. There's a lack of awareness by primary care. There's a lack of services. So the scope is far. It is a lack of practitioners. It is a lack of training. It is a lack of data. In order to understand the scope of the problem for our professions, because we know there isn't a reliable health workforce data. As well as that, the capacity of our current practitioners is they are stretched, so they have high caseloads, and that impacts their ability to deliver service, as well as the nature of Canada and the fact that there are rural populations that are even harder to reach. So I would say, yes, the scope is far-reaching. My colleague Anne may have something to add.
And you are a speech.
I am a speech language pathologist. So I think, one of the big challenges, especially when we're talking about that 0 to 3 ages, currently you don't have speech language pathologists embedded in daycares. They're not there. And a lot of times the primary point of care, so family physicians or early childhood educators, don't necessarily feel comfortable in recognizing and identifying speech and language or communication delays. We can often think about it like an invisible kind of crisis, because if it's physical, you might see it. But for these speech language delays, it's something that it's harder, it's nuanced. As speech language pathologists,
it's not invisible to us. We see it, but we're not in the places where we can get the child to access the services that they need.
Now, even if you could identify a child, say at 2, who's not just quiet, but is actually exhibiting indicia of a speech or communications delay, if they were attached to a speech-language pathologist, is our system responsive enough that that child will get enough therapy, the therapy that they need to actually make a difference?
Well, we can both take that. I would say even if the child is identified, there's still a lack of access to care because there's not enough speech-language pathologists and they're not working in the areas where they are needed the most. So even if we do progress in early identification, we still don't have enough and we still need a better approach and we still need a broader integration into primary health care teams as well.
Now, are children from disadvantaged backgrounds at higher risk of developing speech and language disorders than their peers? And second, we pride ourselves in this country on having universal access to care. Do kids from poor backgrounds get the same kind of access to treatment that kids do from families, for instance, who are able to pay out of the pocket for SLP services?
I think there's a lack of public awareness and education around the identification of speech and language disorders, and I think what we do need, and maybe we could be working with the Public Health Agency of Canada to educate the public around the factors that place infants and toddlers at risk for speech and language disorders, and we need to understand the conditions that ensure the optimum development of speech and language abilities, and we desperately need the appropriate referral pathways to our practitioners to support the care.
Okay. I want to turn to hearing, because it's speech, language, and hearing Canada. Are hearing services consistently covered under provincial and territorial public health care programs across Canada today?
So no, there's an inconsistent approach across provinces. I think 5 provinces are doing relatively well on their early hearing detection and intervention programs. So there's also not a universal approach to hearing screening, and we need to do better.
Now, we've just been through COVID. A lot of healthcare professionals have tried to shift care to virtual models with some success. To what degree have speech-language pathologists and audiologists been able to replace in-person visits with virtual care over the course of COVID-19 pandemic? And do you see any prospect for improved access to care using technology in the future?
Yes, so speech-language pathologists and audiologists have, by and large, transitioned to virtual care as a means of supporting access to speech-language pathology and audiology services. And the federal government's funding of $240 million in 2020 certainly helped. However, we still need to expand and launch virtual care and mental health tools just to Canadians in general. Access to additional funding for our practitioners will help them expand the technology that they need in order to properly deliver the care. That includes digital platforms. There's a lot of our members who've moved away from the public system into private practice because of funding cuts. And those practitioners need additional technology to support the delivering of the virtual care. So while as we have adapted and we support the use of virtual care, more can be done to support the practitioners who need to deliver it, who also have to align with the requirements of the Accessible Canada Act.
Thank you, Ms. Wilson. Thank you, Mr. Davies. Next, Dr. Ellis, please, for 5 minutes.
Well, thank you, Chair, and thank you, everyone, for coming. If I might really underscore the childhood crisis that we have at the current time, despite having a government that's added more to the federal debt than all of the governments combined, I think it's germane to really underscore this issue. From September of 2020 from UNICEF, Canadian childhoods are in crisis, according to a new report released today by UNICEF Canada. UNICEF Report Card 16, which measures the state of children and youth under age 18 in wealthy countries, ranks Canada 30th out of 38 nations on the most recently available data from just before the pandemic. My understanding is that previously we were 10th out of these 38 countries. So clearly our children are being left and they're falling behind. This is, obviously a significant and weighty issue, and to my colleagues, I think that it behooves us all here to understand that perhaps these 6 meetings that we're having with respect to child health are really going to be a door opener for all of us, and to understand that to create a childhood health strategy for Canada that I think we're all interested in is going to take a much longer time than 6 meetings, but perhaps this will help us focus better on what we really need to be doing here. Anyway, thank you to the witness for hearing that. Dr. Unger, if I may, I understand that your expertise is in resilience, and that being said, obviously this is a huge topic as it perhaps relates to COVID and the ongoing pandemic and the uncertainty that exists. And I guess my question to you, Dr. Unger, if I may, through you, Chair, is to understand better what you think how this is affecting children with the ongoing threat of lockdown and return of those mandates and sanctions without any realization of the science that goes along with it, and to understand better what may be helpful from a perspective of the government if they were to release this elusive science that they refuse to share.
Well, thank you very much for the question. I won't necessarily get into the politics of what's being released or not, but what I can say is that we do know that children have taken on a disproportionate negative effect of, if you look at depression scores or anxiety from Statistics Canada or Public Health Agency of Canada statistics, we know that it's children that have disproportionately showed increased or elevated levels of these particular mental health disorders throughout the pandemic. Basically, the older you were, the less you were affected, at least from a mental health point of view. So very much we sort of downloaded the crisis. While the physical health crisis was on the elderly, the mental health crisis was largely visited on our children because their lives were the ones that were so disrupted. Anyone who has a teenager would know that all those sporting activities, the rites of passage into adulthood were disrupted. And that has taken a toll. So I think I am very cautious when I look at any imposition of new regulations. I am very cautious that most of those regulations are being imposed in zones like children's or children's activities. And the consequences are being felt most by kids, even though the impact or the benefit is being accrued in terms of health consequences for the adults, the care providers, the teachers, and that type of thing. So there's a fine line to walk here between disadvantaging our children and, in fact, trying to keep adults healthy. And if you look at, say, the work of Sarah Austin at the Children First Canada, you'd certainly see that what we're trying to do is advocate more so that we can actually think about the needs of children before we put these policies in place. And indeed, let's be real clear, there are long-term consequences as we disrupt children's lives: depression, suicidality, long-term developmental challenges, and as my colleagues here on all the medical side of this are showing, that whole sort of delayed diagnosis of pathology that is occurring in children's lives that has lifetime consequences, delayed educational gains, delays entering post-secondary, delayed productivity. So I am definitely on the cautious side in terms of imposing new regulations. I was very much for them previously. Of course, we were in a pandemic, but I am very cautious about carrying these on too long term in terms of children's mental health.
Underscores very urgently the need to make sure that the Canada Mental Health Transfer, so promised by this government, is delivered upon. And I also think it also behooves this government to ensure that the science and the mandates are well supported and that they're well broadcast out there amongst those who perhaps care for children and have children like many of us here do. So thank you, Mr. Chair. Appreciate that.
Thank you, Dr. Ellis. Next, Mr. Vancouverden, please, for 5 minutes.
Thank you very much, Mr. Chair. Thanks to all of the witnesses for being here today and for all of your testimony. I have 3 questions for 3 witnesses, so I just ask that your answers be as brief as possible. First, to Dr. Tompkins, you stressed the importance of oral health for children being the most preventable and most prevalent health concern for children in Canada, as well as the leading cause for missing school. In your work and experience, do kids in lower income Canadian households typically have access to the same oral health care as their middle class and wealthier neighbours?
Well, no, because of all the reasons that we've just talked about. Cost is a barrier. Sometimes language is a barrier. Sometimes the education and awareness of the parents is a barrier. And so with this new program that's coming out right now, that would be one of the things that we would like to see, is that people who are eligible be made aware of this Canada dental benefits so that they can bring their kids to the dentist. So yes, absolutely.
Do you have any recommendations for spreading awareness and ensuring that Canadians are as cognizant of the need to visit the dentist as we can?
Well, certainly as the Canadian Dental Association that represents 20,000 dentists from coast to coast to coast, we'd be happy to partner with the government to make everybody aware of it.
That'd be great. Thank you very much. You also highlighted the need for better dental services for people living in Indigenous and remote communities across Canada. This summer I was lucky enough to visit beautiful Cape Breton University to discuss how recruiting people who are actually from and live in some of these remote and Indigenous communities across the country to those schools in order to ensure like a longer term solution rather than recruiting people just to go for 6 months or a year or something like that. Does the Canadian Dental Association have a position on being able to even use some of the newly minted virtual technology that we all avail of ourselves to train potential dentists in rural areas so that they can practice at home for the duration of their career?
We don't have a formal position on that, but it raises a very interesting idea. So Dalhousie would be the closest dental school. There are 10 dental schools across the country, 3 in Quebec, 2 French language, and 1 in almost every province, and then 1 in the Atlantic region. I do know that the University of Toronto, where I am on staff, we are looking at satellite clinics and actually going out into communities where there are going to be students that are interested. So a dental school in and of itself is an extremely expensive proposition to build. It's like building a hospital that is almost entirely privately funded. So I think utilizing any kind of, and dentistry to a large extent is still very hands-on. There's not a lot of dentistry we can do virtually. So I think to the extent that we can use technology to recruit students, prospective students, and students from all income levels and from all groups of Canadians, that is something that all the universities are interested in doing.
And just very, very briefly, if you could, I've visited a foreign credentials qualifications school in Mississauga, specifically for dentistry, so that we can maximize the number of dentists in Canada. Do you see practical application for more schools like that to ensure that people who are qualified can get to work in Canada?
Well, I think the system that we have right now, which is the National Dental Examining Board system, is very equitable. It's very skills-based. It evaluates people on their actual ability to do dentistry. We do have one of the highest standards of dental care in the world, and our dental schools are among the top in the world. So I think we want to make sure that we maintain a balance of providing enough dentists, and currently there are enough dentists in the country. We have a bit of a maldistribution issue, but we have enough dentists. So we want to make sure that we maintain the high standard while having an equitable process for bringing foreign-trained dentists into the country.
Thank you, Dr. Tompkins. My next question is for Ms. Wilson. Ms. Wilson, former Secretary General of the UN, Kofi Annan, famously stated that literacy is a bridge from misery to hope. He talked a lot about its ability to fight poverty and being a building block for development. Full disclosure, my partner is a researcher and a speech-language pathologist herself studying literacy. Same question to you. Do families in lower-income kids in lower-income families have the same outcomes when it comes to literacy and the determinants of health related to reading and hearing as their middle-class and wealthier neighbors?
I would have to say no.
That's what I was looking to hear. It's important to recognize where the system leaves people out. My third and final question is to you, Dr. Unger. You mentioned a really troubling statistic that the world is seeing a rise in preventable diseases like polio, something that was all but eliminated by vaccination. Yet we have politicians questioning the usefulness and practicality of compulsory vaccination programs in Canada, fighting diseases like mumps and rubella, polio, and many others. Do you find it troubling when politicians question these types of programs in Canada?
I find it extremely troubling when politicians step beyond their expertise and enter what is the domain of simple science, and where we could actually get, really, really good decisions on scientific merit. I would also encourage those same politicians to take a trip to other countries and other parts of the globe where these diseases are still debilitating the lives of millions of children, and then see if we'd be so flip about what we decide here. I just think it's I travel the globe on a routine basis, and it's a completely naive position I just have no, it's just mind-boggling that anybody would take these positions. And we have seen the impact of that, of course, when it came to COVID as well. Vaccine hesitancy, in a sense, we had the drugs, we didn't have the sociology to help us understand what was about to happen, and the hesitancy that resulted in deaths and continues to result in deaths.
Thank you, Dr. Unger. Mr. Van Couverden. Suite, M. Perron, pour 2 minutes et demie.
Oui, merci, Monsieur le Président.
Yes, Mr. Perron, 2.5 minutes. Thank you, Chair. Back to you, Ms. Wilson, if you can hear. I would like to go back to one of your earlier answers. You said that several professionals had left the public system to go into the private sector for want of funding. How do you explain that? Why is there not enough funding? Do you think that the government budgets for primary care is insufficient? Is it a good idea, I'm repeating what I said earlier perhaps, is it a good idea to increase federal transfer payments for health, first and foremost?
It is a good idea to increase federal transfers for health, but the concept of strings attached to those transfers needs to be embedded in whatever transfers are there. How provinces and territories spend their money is not always where we would want it to be. So I do support the concept of the health transfer, but there needs to be strings attached.
Pour de l'argent qui serait pour la santé. D'accord, merci.
For money for health. Thank you. Dr. Unger, you mentioned in answer to an earlier question that you are always cautious when it comes to implementing any new regulations. Could you elaborate? Could you also tell us whether it would be possible to increase funding for proximity governments? You were talking about decentralization of decision-making as being very important. And finally, because you're going to have about 30 seconds to answer, are you concerned with the fact that the allocation of the funding allocated will not all necessarily all be used for health? Let's say somebody will have to provide only a partial bill, but will then get the whole $650 back, and they won't have to justify how they used it. I'd like to hear what you say about that.
Actually, I don't have a lot of familiarity with the last piece of that, so I think that's a really political decision about hopefully families are encouraged and that funds does go to what they do. But I will say that in terms of the actual money flowing, where I'm perceiving from my perspective is this is not always a case of more funding. I know that is not politically astute to say. I'm not a politician. What I will say is that often now it's about the service delivery models being dislocated. So much of what my colleagues here have said today is about if we could be better at co-locating services, like some initiatives nationally, which I can certainly give you some details on later, have done. Part of this largest problem is we have lots of money flowing around. It is incredibly wasted in many cases. It is not coordinated, and children and parents have to get to multiple domains to get services rather than us thinking from the point of view of the families and putting those services together better so that indeed it would be more cost effective and indeed we'd be catching more of these the pathologies earlier. It's a systems problem in part, not just basically throwing more money at these problems.
Thank you, Dr. Unger. Merci, M. Perron. Next, Mr. Davies, please, for 2.5 minutes.
Thank you, Dr. Tompkins. I want to just first of all express our thanks to the Canadian Dental Association and frankly all of your members for their contributions to public health in this country. And I know dentists across this country have long been bothered by their inability to provide necessary dental care. As you pointed out, oral health is primary health care. So I'm really looking forward to allowing dentists to be able to treat more people for this essential health need. Can you give us an idea, Dr. Tompkins, approximately how many children across Canada currently lack sufficient coverage to access the full suite of recommended oral health services?
Well, one of the numbers is actually in the government's background for this program. An estimate of approximately 500,000 children could be eligible to access this program. So I think that's probably a good starting point.
Right. And The CDA's written submission to this committee noted that remuneration rates for dentists vary significantly under existing provincial and territorial dental care programs for children. I'll say it bluntly, dentists have been underpaid generally by the province's programs, so that to the point where often they're subsidizing the care that they have to give. Can you outline the impact that that variation has on dentists' participation in these programs?
Thank you for that question. There is considerable variation across the country. So if you go to provinces like Newfoundland and PEI who do have programs, they are funded well enough so that dentists are reimbursed for the costs of providing care and the ability to make a living while they're doing that. In other provinces, programs have been chronically underfunded. Ontario is probably the worst example of that. And so you are right that dentists who do participate in these programs are actually paying out of pocket to provide the care. So every dentist will do what we can to provide care. You know, frequently these kids are part of larger families that we treat in our practices, but it's not a sustainable situation. So we hope to gain a remedy for that.
Right. Well, I just want to say on the record right now that any dental plan that we create, in my view, dentists have to be paid 100% of the fee schedules in the provinces. They deserve to be treated as the professionals they are, and this should not be a program for poor people. It should be a normative program so that people get access to the care they need. I just wanted to conclude by asking about fluoridation. You also noted that only 39% of Canadians had access to community water fluoridation. Americans have double that.
Mr. Davies? Yep, no, that's your time.
Oh, okay.
Yep, thank you.
And what advice you'd give?
Yeah, you're more than welcome to follow up with a written brief. We're going to move on.
Okay.
Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair.
Mr. Perron, the question was the answer to the question went significantly after the 2.5 minutes. I'm wondering if we could just have a 20-second answer from Dr. Tompkins. Is that possible?
Your question started after he told you to stop.
Oh, I'm sorry, I didn't hear.
Yeah. Yeah, no, that's the question was posed after your time was up. But you will get another turn, Mr. Davies. Ms. Goodridge, for 5 minutes, please.
Thank you, Mr. Chair, and thank you to all the witnesses for being present. Dr. Unger, you really tweaked a piece in me and some of what you were talking about, and I really felt like you were probably talking about my hometown of Fort McMurray, where there have been multiple traumas placed on many of these kids, from the fire to the flood and then the pandemic. And I'm just wondering if you can elaborate a little bit on what communities can do and what individuals can do to help build resilience in kids that have experienced multiple traumas.
Well, it's a great question, and what we are seeing is thank you very much for the question. What we're seeing in other communities is the need for a more coordinated approach. So, my own work is largely in Drayton Valley as one of the Canadian communities. It's also an Albertan community heavily reliant on oil and gas. And what we're learning from those communities is that we, as well as, by the way, Indigenous communities in this country too, but what we're learning is that we need to be thinking about children's lives in more total ways. Recreational spaces, access to green spaces, access to safe water, access to the healthcare professionals that we're hearing about on this particular panel, better coordination and access for childcare, for families, et cetera, et cetera. And I think sometimes what happens is that when we have a mass dislocation or a problem, we tend to focus in very quickly on a particular solution, like, education or speech language or teeth or whatever. And what we're actually seeing in our research is the more we are able to, in a sense, co-locate, think about a child's life in its totality. So, for instance, I'll give you a very small example. It's not really a child example, but when Fort McMurray, there was a big effort to get insurance adjusters to respond to the families that were dislocated after the large fire that occurred. And the insurance adjuster became part of a mental health team, in a sense, because when you get people with insurance claims settled very quickly, families can relocate back to the community, people get back to work, and indeed family cohesion. Children's mental health is better protected when their parents are back at work, houses are reestablished, homes are reestablished, communities are reestablished. Sometimes what we do is we tend to partialize this. We tend to think, oh, let's just give a psychologist to go visit a family. And what we miss is, and I'm a mental health professional, but we miss the fact that without these other coordinated services, trauma tends to persist. And sometimes it's these other allied services. For instance, we know that a child that's better diagnosed with speech language issues is better ready earlier, is better ready for school, and will have higher school achievement throughout their life. We need to be getting out of this idea that we keep funding single solutions in isolation of others. And I think what happened in Fort McMurray is just simply another example that when we think more holistically, we will get better long-term outcomes.
Well, wonderful, and thank you for that answer. And now I'm going to switch gears a little bit to the Canadian Cancer Society. You guys raised some really interesting points when it comes to some of the challenges that are faced with the issues when it came to COVID and getting delayed diagnoses, not being able to have the same level of support when patients were going through cancer diagnosis. So I'm just wondering if you can give us any potential solutions you have to try and get us to not just catch up, but to prevent us from ever having something like this happen again.
I'll start this, Helena, and then you can add. I think what's most important is to continue to place an emphasis on the importance of screening and diagnoses. And so we have seen a shift in some instances to virtual care. And so it would be to continue to encourage parents to bring their children to see their family doctor if something arises in a time where they feel like they're not comfortable to go into a hospital or into the physician's office. So to continue to ask your doctor questions when you have concerns about your child, as well as to encourage the government at all levels to make sure that there is a continuation of those screening programs. We don't want to see an end to screening programs, provided it is safe to do so, but to continue those school-based screening programs when it's safe to do so and when we can. That's a short answer, but Helena, I'll turn to you.
Appreciate that. I've got about 30 seconds left, and there's just one piece I'd like to say. There was a little boy who actually had a very rare form of blood cancer, Ezra Marfo, who passed away, unfortunately, on September 16th. So just last week, a little boy in Lac La Biche. And one of the really amazing things that his parents were spearheading, trying to save his life, was getting more people to swab and get on the stem cell registry. And while it's already too late to save Ezra's life, I would encourage everyone to visit blood.ca so they can swab and get on the stem cell registry, because they could potentially save the life of a little boy or a little girl. So thank you.
Thank you, Ms. Goodrich. Dr. Hanley, please, for 5 minutes.
Thank you, and thank you again to all of the witnesses for the very varied and interesting testimony. I think I'm going to start with Dr. Tompkins. Coming from Yukon Territory, I'm certainly concerned about dental care, as you are, in rural and underserved areas. And one area that I'm quite interested in is the role of dental therapists. I know you've addressed how getting dentists more connected to remote areas and some of the barriers there, surgical centers. But what about dental therapists? We know Saskatchewan has been a leader in that area. I'm just wondering what your thoughts are on this particular cadre, and how we might scale up them as practitioners as well.
So you may recall earlier I said there really isn't a shortage in terms of numbers of dentists in the country, and we receive lots of new entrants into dentistry every year, both from our dental schools and from graduates coming from countries outside of Canada. So I do think the one emphasis has to be on encouraging young people, and certainly in my I teach in the dental clinic, and I talk to dental students about going to places like Whitehorse and Atlin and Hay River and so on, and further north. I mean, that's the Southern Arctic. And the wonderful opportunities that are available there and the great need that's there. So I think first to focus on getting new graduates to be able to come to practice in those areas, because the infrastructure, whether it's a dentist or a dental therapist, is going to be the same. So in terms of dental therapists, there have been success in provinces like Saskatchewan. It's my understanding many of them don't actually end up going out to remote and rural areas. They end up in the larger cities working in dental offices alongside dentists because they can provide quite a variety of services. And not to dodge the question, but I'm going to ask Dr. Burry to talk specifically about what's happening right now with dental therapy in Canada.
If you wouldn't mind very quickly, please, because I have a few more questions.
Just in terms of that, the government has started a new program, which is largely looking for therapists or to educate therapists for the North. So that is certainly a step in terms of replenishing what is a very significant number of retirements in that particular discipline, particularly those that are focused on school-based programs, which is something that we would certainly support in Indigenous communities.
Yeah, thank you very much. For Ms. Wilson, I think you mentioned in your remarks the idea of training early child educators to detect and be familiar with speech-language pathology. And I wondered if you could briefly elaborate on that particular area, because given the real shortage of practitioners, I think we need to expand the knowledge and the ability to screen and detect.
Yeah, I think it's paramount that we work in the early learning and childcare center to improve the outcomes for the early diagnosis. So working with those ECEs directly in their centers is really important, as well as potentially working through the provinces to incorporate our services through the deals that have been provided to daycares. I think it's really also important to stress that if the disorders are not treated, what happens later on and what the impact is. So the ability for us to work in those daycare centers is critical.
Thank you. And if time permits, I may come back to you, but I wanted to ask Ms. Mazzotti or Sonia, the vaping stats that you related are certainly alarming in terms of the increasing trends, although I think the data that you quoted stopped in 2019. And I wondered if you have information on more recent effects, particularly pandemic-related effects. Also, the evidence between vaping and not just nicotine addiction, but tobacco use, and therefore the link to cancer, and what legislative aspects may be needed, all in the remaining 30 seconds that I have. Thanks.
I'll do my best to answer quickly. We're very concerned by the dramatic increase in youth vaping, and there needs to be a comprehensive government response. For example, the draft regulation on flavors and e-cigarettes should be adopted as soon as possible. And indeed, the proposed regulation can be strengthened by removing the exemption of mint and menthol. Among provinces and territories, New Brunswick, Nova Scotia, PEI, and the Northwest Territories have implemented legislation banning flavors. Same with various states in the US, as well as in Europe. So a growing number of countries are doing likewise, including Finland, Lithuania, Netherlands. In all of these places, if they can do this, so can we in Canada. We've made such great progress in reducing youth smoking. We do not need a new generation addicted to nicotine, but that's what's happening. Well, we do support a tax on e-cigarette, and it's essential that flavors in e-cigarettes be restricted. We are concerned. Health Canada has said that e-cigarettes are less harmful than conventional cigarettes. However, a problem is that a large proportion of vapers are still smoking, and we're seeing a rise in dual use. This is also evidence that dual use can inhibit cessation. So we are concerned, and we are seeing a rise.
Okay. Thank you, Ms. Mazzotti and Dr. Hanley. Next, Dr. Ellis, please, for 5 minutes.
Well, thank you, Mr. Chair, and it's a great pleasure to continue on with this. Just before I kind of get started, I want to editorialize perhaps a bit in terms of admonishing my colleague for his analytical line of accusations with respect to vaccines. Once again, we need to understand that those who are vaccine hesitant need not to be divided and conquered and admonished for their choices. They need to be encouraged. They also need to be educated. And continue with this, as I said, acolytic line of accusation is not helpful. Anyway, that being said, if I might, Ms. Wilson, talking perhaps, I think when we originally designed this study, we really knew it was important to begin to understand the effects on speech-language acquisition with respect to masking and COVID. That's kind of where we started with this study. I realize that we've morphed into something else. However, I think it's germane that we undertake that line of questioning, especially with something that we've never faced before. Often people want to then place a tinfoil hat on my head and say, oh, why are you talking about this? This is not an issue, etc. However, if we do not delve into this deeply, my fear, of course, and hopefully it's shared by a multitude of my colleagues, is to understand that not that are they bad for kids in their language acquisition? We don't know the answer to that. Perhaps you and Ms. Carey could help shed some light on that. And if not the light, then perhaps what direction we need to take in the future. So thank you.
I don't think we have enough research at this point in time to show that there's a long-term impact on the speech and language development of children as a result of masking. We know there's an impact. It just actually, as I was waiting to come into this room, my colleague, Ms. Tompkins, and I were speaking, and she was masked, and I couldn't understand what she was saying. So for sure, there's an impact. We don't have enough research at this point in time that I could say with certainty what the long-term impacts are, other than to say that there is most certainly an impact on the ability to understand speech with a mask on, and for children to develop those critical skills during that when masks are being used in schools in particular. I don't know if you have anything to add, because we don't have any research at this point.
We don't have the research to talk about, to give specific data. There are specific at-risk groups, so hard of hearing children might be more at risk and things like that. But
And through you, Chair, if I may again, Ms. Carey, do I understand it correctly that you're a practicing speech-language pathologist at the current time?
I am a registered speech therapist, yeah.
And have you seen issues related to this, or do you think it's still too early, or do we still not have enough of trained professionals like yourself getting the referrals that we really don't know where we are?
We don't have the data, I think, is the cleanest answer for that one.
Okay. And perhaps between the two of you, through you, Mr. Chair, do you have any suggestions for how we might proceed with understanding this complicated problem more fully?
I think we have heard other people here today talk about the need for a reliable source of health human resources data, so we understand the scope of what we're dealing with, because we really don't know. So I think we definitely support any initiatives that the federal government would have to recruit and retain speech-language pathologists and other allied healthcare professionals to improve the situation in health human resources.
Thank you very much for that. And through you, Chair, to Dr. Unger again, resilience is one of those things that is, I think, hopefully fascinating to all of us here. It's really about recovery and how we take on tasks in the future. From your perspective on resilience, do you have any suggestions on moving forward on that topic, on what we need to study in the future with respect to how it relates to the pandemic, in particular with respect to children?
Oh, absolutely. I think what we need to do is to delve a little bit deeper into what were the protective factors, or what it is that actually helps a child get through a crisis like this. There was lots of funding that went out to research studies. Those results will come in over the next sort of year or two. So we don't have a good picture yet. But we did know that children who, say, for instance, maintained routines in their families. We know that families that had access to technologies for kids seemed to do much better. Children that maintained connections with their extended family members seemed to do much better. So some of those hints are there. Might I also say, because I'm a resilience that's what I study, there's a fascinating emerging conversation also about all the, and I say this very, very cautiously because the pandemic was horrific for our economy and many, many, many people died, but there was also huge amounts of lessons learned. Things that we should have known were coming or should have known. So for instance, we saw actually, especially amongst adolescents, more accessible counseling services. Adolescents hate coming to counseling generally, but many more would engage with, and this is anecdotal, but my colleagues are saying that many of them would in fact feel much more comfortable coming to a therapist or seeing a mental health specialist online. We also realized, say in my own home province of Nova Scotia, that for instance, we discovered, surprise, that only 93% of our kids had access to technology at home to access the internet, and that was remedied through school programs and government programs to make sure that kids had access to that technology and internet connections. So some of this simply taught us that we had the capacity to create environments which would help children to be much more successful. And that, I think, is really encouraging.
Thank you, Dr. Unger. Dr. Ellis. Next, Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for being with us today in person. I'm going to focus most of my question to the Canadian Dental Association. First of all, thank you for being here today. Thank you for your submission to the committee and a number of recommendations that you have made. But in full disclosure, I want to disclose that my wife is a restorative hygienist of 25 years, and she's amazing at the work that she does. And I have access to 200 plus oral health practitioner who I proudly advocate for, as well as I fully support my colleague, Mr. MP Don Davis, around ensuring that the level of care provided for those who come to the dentist or they seek oral health, regardless of their income, be maintained at the same level, and therefore the doctors are entitled to the full cost and full compensation for it. I want to go back to the recommendations that you had made, specifically your recommendation 1 regarding consultation and collaboration on the dental care. And I'm going to quote the summary of the recommendation that you had made. CDA recommends that the federal government proceed slowly and carefully, taking the time to develop a long-term solution that is well-informed, targeted, comprehensive, and effective. The federal government should consult broadly and with dentists and other oral health stakeholders, as well as collaborate with other levels of government. So I can say that the news around the program that we just rolled out is welcomed broadly by all stakeholders. However, we see that you are cautioning or you're recommending the federal government takes its time and proceed slowly and carefully. Can you expand why you're saying that, and on what basis are you saying that we should proceed slowly and carefully?
Thank you. Certainly. I mean, we have the opportunity to get something going here that's going to have long-lasting effects, and hopefully is going to be a long-lasting program. So it's definitely worth taking the time to consider all of the aspects and to consult with stakeholders, dentists, dental associations, the provincial and territorial dental associations, the provincial governments, and patients as well, the people who are receiving the care. So it's really important in this first phase, and we appreciate that it's an interim phase, that the input and feedback from the providers is taken into account, because we're the ones with all the questions about the practicality of how this is going to work. We've had questions here today that highlight that, the federal government provides the funding, but the provinces decide where the funding goes. There has to be, and I say I'm not a politician, but there has to be discussion between the levels of government. And if funding does end up being transferred to the provinces for dental programs, which is where they're currently delivered, there have to be significant strings attached. So we would certainly want some sort of national standard of care for a basic program. And as I mentioned also earlier, we have 10 dental schools across the country with very, very substantial academic and intellectual depth that can provide information about programs that work, jurisdictions that work well. But right now we have quite a lot of different provinces. We have 10 provinces and 3 territories. We have just as many programs, more than one in each province. So all of that has to be taken into account because we want to avoid the unintended consequences. 2/3 of Canadians have some sort of coverage through employer-sponsored health benefits. All of you would have that. And we don't feel that that needs to be disrupted. And 75% of Canadians report feeling that they have good access. So it's really designing something that is going to address the gaps in those groups that are not currently accessing care. So it's complex.
Thank you. I have a list of questions that my network has asked, and I'll gladly share that with the government and the ministry. However, if you could share with us the top issue that actually the dentists have regarding the rollout of this program around fees, I would really appreciate that.
Well, one thing that's important, we would not like to see something that adds to the administrative burden. So we don't want to be the gatekeepers on determining eligibility and having to chase patients and to make them verify. That really comes between the doctor-patient relationship. So in terms of the remuneration for the services rendered, and I mentioned this earlier, that it's not unreasonable to expect that costs be covered and the person delivering care to be able to make a living doing that. We do treat as many patients as possible, and we look forward to seeing more. The other aspect that we're hearing from dentists is that something that existed before COVID and has certainly been exacerbated by COVID is that there's a shortage of dental staff. And dental staff are highly trained staff. The person that assists the dentist in the office is a highly trained individual with a lot of responsibility. And at any one time in Canada, up to a third of dental offices are looking to add at least one person to their staff. So I know this is across the healthcare sector. There's a shortage of staff, but it is something that is affecting dentistry. We will do our best to handle the influx of patients, but that is an issue.
Thank you, Dr. Tompkins. Thank you, Mr. Johari. Monsieur Perron, for 2 minutes et demi.
Mr. Perron, 2.5 minutes. Thank you, Chair. I'd like to continue, Ms. Tompkins and Mr. Burry. Do you consider that Bill C-31 is dental insurance?
Vous considérez que le projet C-30...
Do you consider C-31 to be dental insurance? The bill C-31.
No, if you look at it, it's more like a health spending account.
Voilà. Est-ce que vous êtes inquiète du fait?
Are you concerned by the fact that the entire amount of money may not be used for dental treatments? Based on my earlier explanation and the proposed operations in the draft legislation is that people only have to produce one bill and they'll get $650 per child. So you could provide a $100 bill and get $650 back and have to give no account of how you spent the other $550. What's your opinion? Are you concerned about that?
Well, certainly we would like to see the money be put towards dental care for children. And whether or not the person actually does it, as I understand, CRA has various mechanisms for audit and for checking on how the money is used. We wouldn't want to see dentists having to demand that patients justify how they're going to spend the money that they've received.
Là, j'entends bien votre réponse, mais
Well, I hear what you say, but in your previous answer, you said that you were worried about the administrative burden and that could accompany all of this. So, of course, you want the money to be used for dental care. I understand that. Do you think that if the money were to be decentralized to the provinces, this could lead it to be better administered and have less additional paperwork if you don't add another level of government to the healthcare system?
Moi, j'ai ce souci-là.
Because I have that concern.
I cannot answer because that's in the design of the program.
Mais est-ce que pensez-vous que ça a de l'allure?
But do you think it makes sense? Because you raised the concern of the administrative burden. So I usually work on the Agriculture Committee, and we see the same problem. Every time we have to deal with the federal government, it's very complex. It takes so much time. It's very bureaucratic. There's already a level of government responsible for health. Don't you think that by transferring the money we could ensure that proximity services would be the ones who make the decisions related to the reality of communities?
Brief response, if you can, please, Doctor.
Sorry.
Yeah, I'm really sorry. I'm getting lost in the translation here. So, the current what we have now, I refer to it as a health spending account. So, in a sense, the administration of that is very, very simple. going forward, whether or not we have a federal program or whether we have transfer to provincial programs with the accompanying administrative burden, we would want to be able to see something that utilizes the current system. So when you go in to see your dentist, you present, they take your claim, they send it directly into whatever the payer is going to be. That would be the preferred system of doing it. Whether that happens at the federal level or the provincial level, that's not for us to decide.
Merci, Mr. Perron.
Thank you, Mr. Perron.
For 2.5 minutes.
Well, thank you. Well, just to clear some of this up, I have read C31, and of course, a person to get the money does have to attest that they will use the money for dental services, has to keep the receipts for dental service. And of course, you know, when we send Canadians the child benefit payment every month, we have no guarantee they're going to spend it on their children either. But we still send the money to families. And Mr. Prun just made a wonderful argument for why Canadian healthcare transfers have to have conditions attached to them so that we can make sure provinces spend it on the things that they're being transferred for, much like he wants to make sure that this money transferred to families ends up being paid for dental care, I would suppose. I want to finish my question I asked before. The CDA's written submission as committee noted in 2017 that only 39% of Canadians had access to community water fluoridation, whereas 73% of Americans had access to that in 2018. How important is fluoridation to oral health, and what steps should the federal government take to try to encourage fluoridation of our water?
It's extremely important to oral health because if you get community water fluoridation and you get fluoride added to the water in the right amount, it will enable those teeth to be stronger. I'm a benefit of that myself, probably you are as well. But it does come down to the municipalities deciding whether or not to update their infrastructure. So whatever the federal government can do to support the infrastructure that is going to, first of all, have good water systems. In the beginning, we need to have good water supply, and to make it possible for those municipalities to add the fluoride to the water through their support.
Thank you. Ms. Douglas, a quick question. I'm just wondering, what is the impact of children not having access to pediatric, say, oncology formulations? To be really brutally blunt about it, do children die as a result of not having access to formulations specifically for them?
So the challenge with the lack of pediatric formulations for children results in using adult formulations off-label. So what this tends to mean for children is compounding of drugs. So in some forms, it's a pharmacist in a hospital, or a pharmacist either in a hospital setting or a community pharmacy setting crushing a tablet. It could sometimes be parents themselves crushing tablets, mixing it with applesauce or something like that for their children to take the medication. But the problem is sometimes children find it difficult they don't like the taste because sometimes the medicines, when they're compounded, they have a taste to them that children don't like. And getting adherence from children to take their medication is difficult in the best of times, so this makes it much more challenging. So the advantage of having specific pediatric formulations is you can make medications in forms for children that are appropriate, like syrups for younger children, micro tablets, but with syrups, flavors that children like, that children are going to be more compliant with in their therapies as well.
Thank you, Ms. Douglas and Mr. Davies. Next, Dr. Ellis, please, for 5 minutes.
Well, thank you, Chair. And on that note, Ms. Douglas, just to underscore that, as we all know very clearly, those of us who practice medicine at least, that the children are not just little adults. And certainly the Tylenol and Advil shortage that currently exists and the certain significant stress and anxiety that causes for parents really is a way to underscore the need for development of specific pediatric formulation. So I appreciate your efforts on that front. Dr. Tompkins, if I may, through you, Chair, just talk a little bit more about this jurisdictional approach to the proposed dental program. I'm certainly loath to understand why I would believe that the federal government could administer a program in any way, shape, or form that's going to be efficient or effective. That beside the point, of course, that's political. But if these programs exist in 11 of 13 jurisdictions in Canada already, then why do we need a federal dental program?
Well, what we have now is an interim program so that the money is going to low-income families and children who need it. And what we would say is that as part of the dialogue, we would want to be involved as we develop this program going forward, because you are correct. There are programs in existence across the country. They are successful to varying degrees. So some are fairly well funded and work well and reach the populations they're designed to reach, and some of them are not. So there really is a tremendous variation from jurisdiction to jurisdiction. So that is going to be part of the continuing conversation that we have. We represent the provincial and territorial dental associations. They have had the opportunity to meet with the minister and make their concerns known. Each province is a little bit different. It's a lot like Confederation. And so I think if we keep our focus on the big outcome, which is ensuring that Canadians who don't currently have access to dental care, if we can work together, we will find a system that works. And whether it's slightly different in every province, we don't know. Or whether it ends up being a federal program, we don't know. But we are here to provide the information and the feedback on things going forward.
Thank you, Dr. Tompkins, and again through you, Chair, if I may. Do you know which programs jurisdictionally are very successful and which are less successful? And I guess the question is why do we always have to move to the lowest common denominator? Why can't we actually just help those who are less successful be more successful and model their care after those who are more successful? And again, the follow-on question would be then, why does the federal government have to get involved in a provincial issue?
Well, as I've been told and led to understand, the funding comes from the federal government, and then the provinces decide how it's going to be used. So if you look at provinces like Prince Edward Island and Newfoundland, which do have reasonably good programs, but no, there's no program that's perfect. So for instance, as I understand in Newfoundland, they cover certain things, but they don't cover prevention. And in other provinces, they cover different things. So I think from a public policy point of view, if we want something that's going to reach all of the populations, we need to have some sort of a national agreed upon standard that this is going to be the basic dental care plan. And then that will then be part of the discussion. The other part of your question is really part of the debate that's going on between the provinces and the federal government right now.
You know, I guess that's the thing. I mean, if we're having a policy debate, that's one thing. If we're creating legislation that's going to create more bureaucratic issues and costs to create an entirely new program, that seems kind of nonsensical to me in something that already exists. So I just fail to understand, you know, what the need for that is and why we should be supportive of this. That doesn't mean that dental care is not important. You know what? I've been a family doctor for 26 years. I see a plethora of dental problems that could be easily prevented and treated. And as you well know, Dr. Tompkins, I understand you were a practicing dentist. You know what I treat them with is antibiotics inappropriately. And that being said, then, I just continue to fail to understand if we have programs in 11 of 13 jurisdictions, why don't we make them better instead of creating a new program? Why don't we, if we want a strategy on this, wouldn't it make more sense to say, hey, let's make a strategy? But why do we need to spend all this money on a program that, to me, is looking for a home? I guess I'm wondering, you know, what does the CDA think of that?
Those are all very good points. As I understand, with the current Canadian dental benefit, this is something that has a finite lifespan. So, as I said, this will be part of the ongoing dialogue. And I don't know if Aaron wants to add to that.
No, essentially, I think you've outlined some of the things that we would like to see, which is better coordination between the benefits and a conversation about improving programs right across the country at this particular point in time.
Thank you both. Appreciate it.
Thank you, Dr. Ellis. The last round of questions will be posed by Dr. Pawlowski. You have the floor for 5 minutes, sir.
I had a question or questions for Dr. Unger. I was wondering about the available services, psychological support for children who come from war zones. We've obviously had a big influx of such children in recent years, first with Syrians, then with people from Afghanistan, and now most recently people from Ukraine. And certainly, you know and will appreciate the vast majority of kids are really resilient. And certainly I know of kids from Afghanistan who've seen their close relatives die in front of them. I know of Ukrainians who have family members, close family members on the front line they seem to be doing all right. I mean, obviously, all of the kids don't. I don't think all of them need psychological services. But one, do we have enough services to serve their needs? And I guess the other thing is, and I'm kind of thinking of all those people, for example, school teachers who aren't used to this situation. How to identify somebody who maybe needs help, and whether there ought to be any kind of screening to see who needs help among those kids.
Thank you for the question. You raise lots of great issues here. What I can tell you is that for younger children, I think there is a little bit of an assumption, not that you're making it at all. You seem very, very clued into this, and thank you for that. But there is sometimes an assumption that a child will come out of a war zone, and in fact, that somehow that has always resulted in a mental health challenge. And that's not actually supported by the evidence, because many children actually, what they do experience, especially adolescents, is a lot of difficulty transitioning or integrating in during this phase of their resettlement. But because they sort of maintain connections with family, positive identity, they feel like they're not necessarily the cause of their being dislocated. It's not like they did something personally wrong. A lot of those attributions and those patterns of thinking actually are quite protective. So I just want to sort of reassure the panel here that a lot of these children, they do need care, but many actually come with many of the resources to cope well, including our wonderful settlement organizations that are national in scope. Many community groups are religious organizations that adopt these families in their communities, the service clubs, all of that, including educators. All of that creates, if you will, an environment rich in the kind of the mental health supports. My estimate is that maybe 1 in 10, perhaps 2 or 3 in 10 of these children may need some sort of tertiary level mental health intervention. And then you're right. There is a challenge to find culturally competent, linguistically appropriate interventions that would actually match. Now, the good news is that across the country, there are people like social workers who act as cultural brokers. There are community organizations through faith communities that are reaching out to families and children. So there is a lot of sort of grassroots initiatives. And I like that because it takes away that necessity to always be focusing on, a PhD in child psychology that has to treat. And what we're actually understanding is that there's a relatively small number of children that would need that level of care, mostly because we as a Canadian society are incredibly good at wrapping communities and educational facilities around the children who are coming. And we're seeing that. We saw that with the Syrians, and we certainly have seen that with the Ukrainians as well.
Maybe there's no quick answer to this, but most kids are resilient, some not so much. Why the difference? Which kids aren't resilient, and how do you and how can the system try to encourage whatever it is that makes kids more resilient?
So what we see is actually the children who tend to show more of those patterns of coping successfully have both sort of internal strengths. Usually it's just sometimes the genetic lottery, if you will, but more often it's about patterns of extended family, opportunities in their communities to use their talents, recreational spaces, access to a cell phone, technology so that you can remain connected to your extended peer group, language skills, an education system that adapts. There's a lot of factors that you can actually put in place that are well researched that actually create the conditions, the optimal conditions for children to survive well. But of course, as your questions indicate, there are also children whose past risk exposure is so severe or so unique, or they have a constellation of risk problems that you do need to tailor an intervention specifically for them. It's not related to refugee children, but if you look, say, for instance, at the Kids Help Phone, that is a national effort, it's actually overused or used disproportionately by children in rural communities and indeed Indigenous children, largely because it's a protective factor that is very adaptable to people living in more marginalized communities and indeed rural communities. And I think that's where we get thinking about protective factors as really tailored to the risks that a child experiences, while not forgetting that most children respond really well to simply all the good things that we tend to give kids through communities that care about the newcomers that arrive.
Thank you, Dr. Unger. Thank you, Dr. Pawlowski. That concludes our rounds of questions. To all of the panelists, thank you so much for being here with us today. This is our first witness panel on this study, our first of 6 that we have planned. It's a very broad topic, and the diversity of expertise that we had in the room today, I think, reflects how broad the topic is. So thank you very much for sharing your expertise and experience with us. I have no doubt that it will be of great value in terms of framing our thinking as we move through this work. And we are indeed grateful to you for the time that you've given us and the thoughtful and comprehensive way that you've addressed all of the questions. Is it the will of the committee to adjourn the meeting? We're adjourned.